Good morning, doctor. Let us introduce ourselves. We are from SGD Base Milan and we will present about our student project. The title is Precocious Puberty. So there are 12 people in our SGD and here is the name. Good morning, doctor. Let me introduce myself first. My name is Nilu Putiswari Abdadarani. My last ID number is 183. And now I will tell you about the background of our student project. So basically, precocious puberty is a condition where the appearance of secondary sexual characteristics changes prematurely. The prevalence of precocious puberty in the world is tend to be increasing every year. We got the data from different countries. There are U.S., Denmark, Taiwan, Myanmar, and also Indonesia that shows the precocious puberty is often to tend to be increasing every year. The risk of precocious puberty such as it can indicate serious pathology and it can make the stature short due to accelerated bone maturation. And we found that unhealthy diet patterns and also overweight in children have a relationship with precocious puberty. So we should pay attention and take a serious attention to this problem as well. Our four problem formulation for the student project. Number one, what is the definition of precocious puberty? What is the mechanism and etiology of precocious puberty? What is the classification of precocious puberty? And what is the diagnosis, therapy, and prognosis of precocious?
My name is Putu Anita Wirachayani with my last three digit of ID number being 185. So puberty is defined as the time when teenagers become sexually mature and are able to reproduce. Not only changes related to the body's reproductive system, but it also comprises the rapid development of the bones and muscles and changes in the body size and structure. Precocious puberty, however, occurs when a child's body starts transitioning into an adult phase too early. Precocious puberty refers to the onset of puberty in girls before the age of 8 and in boys before the age of 9. The signs of precocious puberty in girls include early breast growth, first period in a very young age, early growth of pubic or underarm hair, acne, and development of body odor. The signs in boys are similar, except that there are early growth of testicles and penis and early deepening of a voice. The cause of precocious puberty depends on what types of precocious puberty is being developed, either central or peripheral precocious puberty. In the case of peripheral puberty, the cause is often unidentifiable. Some of the possible causes, though, includes a tumor of the brain and spinal cord, brain defect present at birth, injury to the central nervous system, and MCQ or Bright syndrome. The second type, which is peripheral precocious puberty, takes place without the brain hormone GnRH that often marks the beginning of puberty in both boys and girls. Instead, issues with the ovaries, testicles, adrenal glands, or pituitary glands are to blame for the release of estrogen or testosterone into the bloodstream.
Greetings, my name is Arianda Bella Maitri Anjasrini with the three last digit of student ID number 188, and here I'll be explaining about the mechanism of precocious puberty, the gonadotropin-dependent precocious puberty or GDPP. GDPP is a medical condition that affects the normal development in children's reproductive system. It occurs when the hypothalamus gland in the brain begins to release hormones that triggers the release of sex hormones from the ovaries in the girls or the testes in boys. This leading to the development of secondary sexual characteristics at an abnormally early age. The mechanism behind this condition involves the complex interplay of several hormones in the body. The hypothalamus normally releases the gonadotropin-releasing hormones, which stimulates the pituitary gland to release the luteinizing hormones and follicle-stimulating hormones. Both of these hormones then respectively stimulate the production of estrogen and testosterone in the ovaries and testes. Estrogen is responsible for the development of secondary sexual characteristics in girls, such as breast development and menstruation onset. In the boys, testosterone plays a role, such as in facial hair growth and voice deepening. Although the precise causes of gonadotropin precocious puberty are remain identified, the idiopathic precocious puberty is the most common causes of GDPP and affects girls more than boys. In some cases, tumors involving the hypothalamus and genetic syndromes such as neurofibromatosis type 1 also have distinct manifestations and are linked to the GDPP.
Hello, my name is Nyaman Gede Wiragunatri Paramarta and my last three-digit number is 180, and I'm going to explain about the mechanism of gonadotropin independent precocious puberty. So, Peripheral precocious puberty or gonadotrophin-independent precocious puberty is caused by excess of sex hormones from the gonads of adrenal glands. Tumors that secrete beta-human chorionic gonadotrophin or exposure to exogenous sex hormones. GIP treatment depends on the underlying pathology. However, in mass or male-restricted early puberty, treatment with aromatase inhibitors and anti-estrogens or anti-androgens has shown partial efficacy in slowing growth rate and increasing adult height. In recent years, gonadotrophin-independent precocious puberty has been described in patients with early maturation of gonadal steroidogenesis or gametogenesis, without levels of pubertal gonadotrophin secreted by the pituitary gland. This unique early sexual development has been described in boys with familial or sporadic male-limited precocious puberty and in girls with McCune-Albright syndrome. So that's all for the mechanism of gonadotrophin-independent precocious puberty. Thank you.
Hello, my name is Neputuni Hormila with last three digits of student ID 201, and now I'll explain about etiology of gonadotropin-dependent precocious puberty or GDPP. So, central precocious puberty or gonadotropin-dependent precocious puberty in girls is generally idiopathic, but in boys there's usually an underlying pathological conditions. There are several categories in central precocious puberty, such as sporadic idiopathic, central nervous system abnormalities such as the presence of tumors, congenital abnormalities, lesions, induction from medical procedures or injuries such as neurotherapy and head trauma, and chemotherapy. There is also a genetic category such as loss of function mutations encoding the MRF3 or Macorin ring finger 3 gene, environment, and syndromes such as Sturge-Weber syndrome and tuberous sclerosis. Post-surgery surveillance should include looking for progression to GDPP to prevent GDPP happen after surgery or tumor removal. The GDPP treatment generally implement is to administer gonadotropin-releasing hormone agonists. That's all I can explain from etiology of gonadotropin-dependent precocious puberty. Thank you.
Hello, doctor. My name is Michael Jonathan Raya, with three last digit student ID number is 182. Now I'm going to explain about the etiology of gonadotropin-independent precocious puberty or GIPP. So, peripheral or GIPP is brought on by an overproduction of sex hormones in the gonads or adrenal glands, tumors that secrete SGD or exposure to exogenous sex hormones. McCune-Albright syndrome or MAS, functional ovarian cysts or FOX, Leydig cell tumors or familial male-limited precocious puberty are also some of the common causes of the gonads producing too much sex hormones. Congenital adrenal hyperplasia or androgen-secreting tumors are the two main other causes of increased androgen production at the adrenal origin. The underlying pathophysiology is targeted in the treatment of GIPP. However, therapies with aromatase inhibitors, anti-estrogens, or anti-androgens have shown some promise in mass or familial male-limited precocious puberty in terms of slowing growth and increasing anticipated adult height. Regardless of the origin, GIPP is substantially less frequent than GDPP. While the pathophysiology and clinical manifestations of GIPP vary depending on the cause, GDPP has a predictable physiologic and clinical trajectory. The best methods of treatment and their effectiveness in GIPP are unknown, and the long-term outlook is also still unclear. Well, that's all from me. Thank you for listening, Doctor.
Hello everyone, my name is Simon Jordana, with my digit ID number 193. And today I will explain about the premature telarchy. Premature telarchy or premature breast development is a benign condition affecting young girls and can be interpreted as a sign of central precocious puberty or CPP. This is postulated to be the result of increased sensitivity of breast tissue to normally circulating estrogen in prepubertal girls, transient estrogen secretion from ovarian follicular cysts, increased estrogen production from adrenal-derived precursors, and increased dietary estrogen intake, contamination, and transient partial activation of the hypothalamic pituitary gonadal axis with exogenous food. With hypersecretion of follicle-stimulating hormone or FSH. Inhibin B secreted by the granulosa cell is thought to be responsible for elevated FSH in case of premature breast development beginning before 2 years of age. Maybe that's it about the premature telarchy. Thank you.
Hello everyone, my name is Ananta Wismaya with the last three-digit number of 198, and now I'm going to explain about premature adenarche. Premature adenarche is a condition that occurs when the adrenal glands start producing hormones earlier than usual. The early production of hormones associated with premature adenarche can result in a range of physical and emotional symptoms. The most common symptoms is the early development of pubic and underarm hair. Other symptoms may include body odor, acne, and rapid growth. The exact causes of premature adenarche are not well understood. However, a combination of genetic and environmental factors may play a big role. Diagnosing premature adenarche can be also challenging, as the symptoms may be subtle and can vary widely from child to child. Typically, diagnosis is made based on a physical examination and blood test to measure hormone levels. In the treatment of premature adenarche, in most cases no treatment is necessary, and the child will be monitored over time to ensure the condition does not worsen. That's all for me. Next.
Hello everyone, my name is Ana Agus Auranik-Suma and the last three digits of my student ID number is 18. Hello everyone, my name is Ana Agus Auranik-Suma and the last three digits of my student ID number is 181. I'm going to explain about gynecomastia. Gynecomastia came from the Greek words gyne means feminine and masto means breast. So gynecomastia is a disease characterized by the enlargement of benign mammary glands in men. By a prevalency of 65%, it usually appears asymptomatic, but some can be associated with pain and soreness in the mammary gland. It often affects 13 to 14-year-old boys and 65-year-old or older men. Asymptomatic gynecomastia can develop at 3 stages of life. First, shortly after birth, because of the stimulation of breast tissue in infants caused by mother's high blood levels of estradiol and progesterone. Second, during puberty, because of high blood estradiol levels throughout the day. Third stage begins at the age of 60 or older, because there is an increase of peripheral aromatase activity. To determine the patient's diagnosis, the clinician needs to do a history exam such as chemical exposures, systemic sickness, as well as the duration and timing of the patient's breast development. Currently, there are 3 types of medical treatment for gynecomastia: androgens to rebalance androgen-estrogen ratio, anti-androgens, and aromatase inhibitors to suppress estrogen production. That's all from me. Thank you.
Hello everyone, my name is Nanda with student ID number 190, and now I would like to present about precocious puberty diagnosis. It will be divided to 4. The first one is physical examination, hormonal profile, imaging studies, and genetic studies. For physical examination, include anthropometric measures, growth rate calculation, and Taylor classification evaluation of secondary sexual characteristic. We can use an orchidometer to measure the testicular volume, differentiate between unilateral and bilateral enlargement, and it could be challenging to distinguish between enlarged breast fatty tissues or lipomastia and real glandular breast tissues. The presence of telarche is indicated by firm glandular tissues beneath the areola for girls. Height change over time should be plotted also on a growth chart, since they can help diagnose premature puberty if they cross one or more pulsatile gaps, and we also can use the formulas to calculate children height. For hormonal profile, estradiol will increase in females and testosterone will increase in boys. And LH peak also there with stimulation with GAN-RH or GAN-RH agonist. Their tests has historically been used to identify CPP. For the hormonal profile, and children under the age of 2 should be cautioned because interpreting gonadotropin concentration since increased LH and FSH level may be physiologically related to mini puberty. For imaging studies, you can study the age of the bone itself. If the bone age is too much for their age, it could be premature puberty, precocious puberty. For genetic studies, there are if their parents or one family member experiencing precocious puberty is often referred to as a familial precocious puberty with the discovery of MKRN3 and the LK mutation in familial CPP. That's all from me. Thank you.
My name is Yoko Resti Putri Madewi with the last 3-digit number 189. In here, I will explain about the precocious puberty therapy. The GnRHA analogs are well-tolerated and highly effective treatment for children with central precocious puberty with no underlying medical condition. Usually includes a monthly injection of medication such as leuprolide acetate or triptorelin, which delays further development. Desensitization can cause by GnRH analogs and downregulation of GnRH receptors, leading to reduced secretion of gonadotropins. Newer developments in treatment says about the efficiency of the subdermal hystrelin implant, which is useful for long-term treatment. In contrast to central precocious puberty or CPP, treatment of PPP or peripheral precocious puberty depends on the cause. Since we still lack information about the long-term outcome after GnRH treatment, as well formulate a good treatment for patients with PPP. More research are required in the future. That's all from me, and we'll continue with my friends. Thank you.
Hello everyone, my name is Amelia Sasikirana Dewi with last digit 207. Today I will explain about the precocious puberty prognosis. The ongoing impact that sufferers can experience will depend on the condition of the disease itself, whether at age the disease attack or how the care is given to the children. Precocious puberty can affect adulthood, lead to an imbalance between physiological and physical development, and possibly even produce psychiatric issues as a result of early manicure if it is not detected and treated in timely manners. Beyond the physical effect, the physiological effect of early puberty should be also taken into account with precocious puberty. Children develop before their classmates, which can lead to a range of emotions. Children's self-esteem and confidence may suffer if they enter puberty early than their classmates. And that's it. Explanation from me. Thank you.
My name is Putu Anita Wirachayani with my last three digit of ID number being 185. So for the conclusion, puberty is when teenagers become sexually mature and are able to reproduce. Precocious puberty, on the other hand, is when a child's body begins to enter an adult phase too early. It will undoubtedly have long-term effects on children's development, particularly on their primary and secondary sexual characteristics. If it is not identified and treated, precocious puberty can result in an imbalance between psychological and physical development and possibly even generate psychiatric problems. Precocious puberty is divided into two categories, gonadotropin dependent and independent precocious puberty. There is a classification of precocious puberty consisting of premature telarch, premature adrenarche, and gynecomastia. To diagnose precocious puberty, a complete medical history should be identified to assess onset, medication usage, symptoms of CNS diseases and traumas, genetic studies, and imaging studies. Other family members should also have their puberty onset information confirmed. And for the treatment, it is based on the underlying disease. However, treatment with aromatase inhibitors, anti-estrogens, or anti-androgens has shown some partial success in MAS in reducing growth rate and raising adult height. Children with central precocious puberty who have no underlying medical conditions can benefit greatly from treatment with GnRHA analogs because they are well tolerated and very effective. It often involves a monthly injection of a drug that prevents further development, such as triptorelin or leuprolide acetate. Okay, so for the suggestion, precocious puberty itself is a disease that involves the CNS, suggesting that this disease could be life-threatening. And the effects of the disease could both affect the physical and mental well-being of a person. And once symptoms develop, it is suggested to directly go to the doctor to get diagnosed. Several ways of diagnosing could be done, including undergoing physical examination, checking for hormonal profile, undergoing imaging studies, and genetic studies. Once the diagnosis confirms the presence of the disease, treatment and therapy should directly be given to hasten the recovery process. The GnRHA analogs are well tolerated and highly effective treatment for children with central precocious puberty with no underlying medical condition. Usually includes a monthly injection of a medication such as leuprolide acetate or triptorelin, which delays further development. Newer developments in the treatment says about efficacy of the subdermal hystrelin implant, which is useful for long-term treatment.
From our presentation, thank you so much for your attention. We apologize if there's mistake in our presentation. Thank you.